अच्छा आप लिखते रहो, ठीक है, आप ही से पूछ लेंगे.
Good evening, sir. So, I am presenting a case of 37-year-old female patient, resident of the Saritawar, New Delhi, a homemaker by occupation, present to our hospital on the date of 19th October this year, and with the complaint of decreased urine output since 1 month, and complaint of bilateral lower limb swelling since 1 month, and complaint of shortness of breath since 15 days.
Don't be fast, slow, धीरे धीरे बोलो, सबको पता चले ना कि आप लोग स्लो बोलो ना बेटा. टी.
So, she came with the complaint of decreased urine output since 1 month, and complaint of bilateral lower limb swelling for 1 month, and complaint of shortness of breath for 15 days. On HOPI, I would like to start my history 8 years back when she was complaining tingling and numbness of the both feet, for which she was evaluated and she was told to have diabetes, for which she started some oral medications. According to her, she took medication for a few months, then she stopped taking stopped taking medicines, and eventually she lost to follow up. Then, since 8 months ago, she came to the OPD with complaint of shortness of breath and decreased urine output and bilateral lower limb swelling, sir. Then she evaluated for the same and told to have a renal dysfunction with the creatinine of 3.1, sir, and uncontrolled blood sugar and high blood pressure, sir.
When was this? You said the history dates back to 8
8
years
years, sir.
back. That means at that time lady was 29 years old.
Yes, sir.
So that is the time she presented with tingling numbness of extremities,
Yes, sir.
and she was told to have diabetes.
Yes, sir.
You said she took some medicine for a few days or few months,
few months,
and she was lost to follow up.
Yes, sir.
When did she reappear?
Sir, 8 months ago.
Just 1 month
Yeah,
back.
yeah, yeah.
So that means for 8 years you don't have any follow up.
Any follow-up,
Okay, go ahead.
She was not taking any anti-diabetic also.
No, sir. She stopped taking medicines, sir. So.
Okay.
So 8 months ago, she came to the OPD with a complaint of shortness of breath, decreased urine output, and bilateral lower limb swelling. Then she evaluated for the same and told to have a renal dysfunction with the creatinine of 3.1, and uncontrolled blood sugar and high blood pressure, sir, for which she was started some oral medication, and her symptoms go relieved over the period of time. Then she was regular on the medication. Then now she presented with the complaint of shortness of breath since 1 month and decreased urine output for 1 month and lower limb swelling for 15 to 20 days, sir. And shortness of breath insidious in onset.
Excuse me, what is her education status?
5th standard, sir.
Huh?
Fifth standard.
Fifth class. Okay.
Yes. The shortness of breath is an insidious onset, started with the climbing stairs and walking uphill, and which gradually increased to the extent that patient had a shortness of breath at rest. Also, shortness of breath aggravated by the lying down and relieved by the sitting position, and shortness of breath associated with the EG fatigability. And she had a decreased urine output since 1 month. Initially, she was able to pass 5 to 6 times in a day, which now decreased to 1 to 2 times per day. And decreased urine output associated with the burning micturition on and off. And there is no history of fever, sore throat, cola-colored urine. Also, there is no history of loin pain and abdominal pain. There is no history of skin rash and joint pain. And there is no history of urgency and frequency and nocturia. There is no history of post-weight dribbling, sir. And she is having a swelling over the bilateral lower limb for a 1 month. Swelling first starts from the face and gradually involves the bilateral lower limbs. Initially at the level of ankle and gradually progress to the up to the level of thigh. Swelling increases by the evening, and there is no history of chest pain and palpitations. There is no history of wheezing cough and any blood in sputum. There is no history of weight loss and decreased appetite. There is no history of intake of over-the-counter medicine, and there is no history of any claudications or blurring of vision. There is no history of oral ulcer or pleurent on bloody nasal discharge. In the course in the hospital, sir, patient was admitted with the above complaint and started on a IV and oral medication. She was told that with these medicines, the urine output will increase. However, urine output did not increase significantly, and she was taken for the hemodialysis in view of persistent symptom. And till date, 3 sessions of the hemodialysis have been done, and now patient is symptomatically better, sir.
This is in your hospital, hemodialysis done?
Yes, sir.
Carry on. I have not really enjoyed the history, but carry on. We will ask him just summarize.
You will present, no? If I will ask anybody, nobody will tell what you have told the history. Don't be so fast in telling the history. It's your time, no? You are going to time. You will have enough time for the discussion. You Just tell us both what is the summary of the history, what you have told right now. I'm not even able to catch up. What is summary in one line? Till
So 37-year female with a
yeah.
poorly controlled diabetes, newly onset hypertension, came with the complaint of shortness of breath and decreased urine output with a bilateral pedal swelling, sir, and found to have renal dysfunction with since 6 months ago. Now she has come with the acute on CKD with the progressive increase in renal dysfunction, sir.
Okay. When she was admitted to your hospital?
So 19th of October,
19th.
yes.
And when she had a dialysis?
On the, sir, started on the 21st.
Okay.
Yes.
Now you go ahead.
Go ahead, complete your history, and then somebody will analyze.
A past history, there is sees a history of the diabetes since 7 to 8 years. History of hypertension is 8 months, sir. There is no past history of TB, jaundice, COPD, asthma, or any blood transfusion, or there is no past history of the CV or any coronary artery disease, and there is no past history of the previous hospital admission, sir. In family history, her mother is having a type 2 diabetes at the age of 50 years, and his father is not a non-case of type 2 diabetic, and she had as her one younger brother and one elder sister and brother. None of them having any chronic illness, and in none of them having a type 2 diabetes, sir. In menstrual history, menarche at the age of 14 years and cycle is regular. In obstructive history, gravida 2, para 2, abortion 0 and live 2. There is no history of gestational diabetes, and there is no history of preeclampsia during the gestation, sir. In personal history, diet is mixed, appetite is adequate, and sleep is disturbed, and bowel habit is normal. There is no addiction of alcohol, tobacco, and any substance abuse. Then bladder frequency is reduced to 2 times per day since last 2 months. In a urine dipsticks are glucose 2 plus, protein 2 plus, blood nil, ketones are negative, and in a urine macroscopy there is RBC 4, pus cells 3 to 5, protein 2 plus, and there is no cast and crystals, sir. So I summarize the case. This is a 37-year female with a poorly controlled diabetes since 8 years with a poor complaints and newly onset hypertension in 6 months. Present to us with the complaint of decreased urine output and lower limb swelling since 1 month and shortness of breath since 15 days with the no other systemic complaints, sir.
What was the urinary finding? Urine protein 2 plus.
2 plus.
RBCs?
RBCs are 4 and pus cells leukocyte 3 to 5, sir.
Pus cell how much?
3 to 5, sir.
3 to 5.
Yes.
This is normal or abnormal?
More than
RBC and pus cell. These are the normal findings or abnormal findings?
Sir, if there is a more than 3 RBCs in a high power fields, including microscopic hematuria.
How many are there, you said?
4 RBCs, sir.
4 RBCs.
Yes.
Can you summarize what he has said? And then analyze the case. You're finally here. Yeah. Just analyze what he's saying. He has given you history. Lady is a known diabetic of 8-year duration, non-compliant with medication. 6 months back, she is picked up to have hypertension. Now she has presented with gross fluid overload and breathlessness. That is the history he has given. Now you analyze, what do you infer from this history? Number one, she is a diabetic. I think, what percentage of world population is diabetic? Make your own guess. Or how many diabetics are there in the world, if not in the world, in India?
50 billion in the world.
How many? 40%. That you mean to say 40% of the population is diabetic? Final year. No, that's you have to be very clear. You have always to take age into consideration. As on today, India has got please sit down. India has got 64 million, or 60, maybe 70 today. That means 7 crore Indians are diabetics. If you look at the figures, how much is the adult population in India and how much is children are below 18 years? Rough. Any idea? Young population is very predominant. 45% of Indian population is below 18 years of age. and 50-55% is over 18 years. So if you talk of adults, so almost 50% will become adults. So out of 140 million, whatever billion we have, 40 million. So you will have 70 million as adults, or 75 million. 65 million will be children. So as you said, India has 70 million diabetics or 7 crore diabetics. That means 10% of the population adult is a diabetic. That you should be aware of. Like 10% of population has got CKD or 10-12%. Likewise, if you go on increasing the age, please sit down. I remember uh, when we were students, we indulged in a survey in Delhi. That time I was in Maulana Azad. So that time we did in 71, I'm talking, we did a survey. Not we, I mean, we were just the small people that time, students. So the teacher, he was doing survey. In Delhi, 2.1% of the population had diabetics. Today, if you look at adults in India, even in villages, so whenever you talk of what is the percentage, go by the age. If you go over the age of 25 years, maybe 15% are diabetics. If you take over 40 years, 20% will be diabetics. So take age into consideration. It has profoundly in last 50 years, from 71 to 23, in 52 years, the percentage has become 10 times stronger. So you know that diabetes is a pandemic and it is increasing. So that is the figure in Indian scenario. Now analyze. You were analyzing.
37-year-old female with poorly diagnosed diabetes mellitus at the age of 29 years. And she was not on any medication and lost a follow-up for 8 years. And then 6 months back, she presented with.
No, that he has analyzed. Now you have to analyze what really happened.
So we have to rule out any other end organ involvement like diabetic retinopathy.
You are also final year.
Second year, sir.
Second.
So you want that. But keep in mind, one important point is that 8 years back when she was diagnosed to have diabetes, what was the presenting complaint?
Tingling and numbness.
That means she had neuropathy at that time also, isn't it? So the presentation was possibly, that is why you say whenever we talk of diabetes, we don't know when did it start in adults, how many years back it started. So possibly it started much earlier in this patient, and by the time she reported, she already had neuropathy. Which are the predominant areas involved in diabetes? Capillaries involved. Which capillaries are involved? You know that. What happens? So these three are areas where you can see or know about the capillaries. So you say retinopathy, and retinopathy you see in retina. But keep in mind, predominant blood flow in the eye is in the arachnoid, second layer. You've got sclera, in between is choroid, not arachnoid, choroid plexus, and then is the retina. 97% blood goes in the choroid, but you can't see it. You can see that 3% retina, that is why you say retina. Alright. So retinopathy, neuropathy. So the lady possibly had issues that time. You have not mentioned in your examination about retinopathy. She wants to know.
Neither in history. Just a minute. You tell us everyone what is the natural history of type 1 and what is natural history of type 2 diabetes mellitus. Then it will be clear to everyone.
Sir, according to Sir Mogeson's hypothesis in a type 2,
Huh?
Mogeson's hypothesis which is given for the type 1 diabetes, in a, which is if patient diagnosis with type 1 diabetic, then after 5 year of age, then there is a hyperfiltration and intraglomerular hypertension, sir. Then after next 5 to 10 year, there is a moderately increased albuminuria, and then next 10 to 15 year, macroscopic albuminuria, and after 25 years there is ESRD, sir.
Yes, good. So there is a type 1 diabetes is having natural history typical, what he has told right. And type 2 diabetes, what is its natural history?
Sir, type 2, this basically patient can present with a renal dysfunction or macro or microalbumin at the time of diagnosis as well,
Yes,
because there is an
true.
unknown
Because always
asymptomatic.
remember in type 2 diabetes it's a heterogeneous. It is genetic, heterogeneous, so many factors. So presentation, when you first time diagnose the diabetes, you will diagnose with the complications. What are the microvascular complications? You know, micro बता क्या क्या होते हैं?
Cardiovascular events such as MI and stroke, neurovascular.
क्या क्या?
Stroke, MI, stroke.
MI और ब्रेन का स्ट्रोक हो गया और असली चीज बताओ.
Peripheral vascular.
That is most important. So the exam they will ask the very basic question.
So there is a micro, you said, and macrovascular complications. Why it happens? What really happens to capillaries or blood vessels? What is happening to them? You have to know that there is a glycation and there is glycosylation. Glycation is sugar is binding to the collagen of the blood vessel. So the blood vessel wall gets hyalinized, it becomes weaker. Glycosylation is enzymatic binding. Glycation is non-enzymatic. So that is how the first changes start in the basement membrane. So because that becomes glycated and then gradually it becomes hyalinized. What is happening in the capillaries, in the eye? Because you say the capillaries, the wall is getting glycated, so it becomes thickened, the capillaries become narrow. And once it is narrow, there is hypoxia ahead. Because of hypoxia, now capillary tries to give more blood, it dilates, what you call microaneurysm. So it is dilating, and then gradually, after that, blood will flow, then again hypoxia, again microaneurysm. So that is what in eye, the first change what you detect is by fluorescein angiography, you will do a leaky capillaries because the capillaries will leak out. The wall is hyalinized and leaky. And second change will be because the basic etiology is hypoxia. Because of hypoxia, now the capillaries, they will start having microaneurysm. And after the microaneurysm stage, because the wall is weak, then all that exudates and hemorrhages will start. What is proliferative retinopathy?
When there is a formation of new vessels in retina, that is proliferative.
Again, simply because of hypoxia. Because the hypoxia is there, it is not supplying blood. So neovascularization and so neovascularization one, and then hemorrhages are there. They are part of non-proliferative. They will occur that time. Then there's a retinal detachment because of fibrosis. So that is, and what is, you should know what is cotton wool exudates. Anybody? You say there are exudate, you said. So there are hard exudates. Hard exudates are lipids and fat. They have lipoproteins have come out. And what is soft exudate? They are Shabbat. Good. They are infarcts. Because of hypoxia, when there is no blood going there, so there is an infarct. That is pre-proliferative retinopathy. So if a person is having soft exudate, you should know that is very bad. Hard is not bad. That is pre-proliferative, but soft is bad. Okay? And likewise, you said neuropathy is occurring and kidney damage.
Non-proliferative में क्या होगा? चलो this खत्म हो जाएगा.
Yes, sir.
But what changes you will get in non-proliferative retinopathy?
In sir,
Retinopathy complete हो जाएगी ना?
yes sir. The one is sir venous bleeding, and there is a and microaneurysm, sir.
Non-proliferative.
You said that. You were saying you can complete that. Anybody?
Non-proliferative retinopathy में क्या मिलेगा? Main feature बोलो. Macular edema मिलता है. ठीक है?
So microaneurysm, you have got exudates and you have got hemorrhages. So depending on where the hemorrhage is, if it is deeper tissues of retina, you call it dot. If it becomes little more superficial, you call it blot. If it becomes absolutely superficial, you call it flame shaped. So it depends on where the bleed has occurred.
Let's come to the history. If you have examined the fundus finding or
Yes.
any fundus finding institute has been done, that's why sir it is good. Suppose we get the positive finding, then we are 100% sure we are handling diabetic nephropathy. They are very strong possibility by history. So let's come to your patient. He presented with deranged renal function. You
Yes.
are not telling the deranged renal function. With signs of fluid overload. The only indication was the fluid overload or something else.
No, sir. There was a fluid overload basically.
Okay.
Yes.
Fluid
without-
overload.
Yes.
Then how many dialysis you have done?
3 dialysis. 3 sessions of dialysis.
Now patient is okay.
Symptomatically better, sir.
So you tell me your plan of action, how you plan for this patient.
No, is he off? Is she off dialysis or she is on maintenance dialysis now?
No, sir. We are planning for maintenance dialysis.
She is on
Yes.
maintenance
Yes, sir.
dialysis. So she has already reached.
Yes.
So which stage, Dr. Saab is asking, which stage of diabetes she has come to you now?
CKD, sir.
उसके बाद में आप how you will plan, how you will manage, what you will tell to the patient. Huh?
Sir.
You know, these are the tests you have got permanent failure or temporary failure.
Yes, sir. So,
You
sir,
tell me.
first we, sir, counseling patient for the permanent vascular access, sir.
Hmm?
Permanent vascular access, sir, for dialysis for the in future, sir, maintenance for the
Your
maintenance.
urine findings are in favor of temporary or permanent. Because you have got urine examination.
Yes, sir. There is a temporary
You have to
finding,
examine by your,
and also, sir, the progression of the disease is very fast.
your history and urine finding goes in more favor of chronicity.
Yes, sir.
Right? There is nothing active in your urinary finding. This much RBC, WBC you can get in diabetic nephropathy.
Yes.
So you tell me, have you done the fundus examination?
Yes, sir.
What
In,
was the finding? I'll tell you.
in NPDR, sir, and
Huh?
NPDR, non-proliferative diabetic retinopathy, sir.
Non-proliferative
In the left eye and right eye is
Ah.
normal, sir.
The thing is that for last 8 years she is giving you history. She was diagnosed, then she has stopped medication, all these things. That's why she progresses so fast. Anyhow, anybody can, it's a heterogeneous force, can
Yes.
progress to end stage renal disease more early. But if suppose her blood pressure was controlled on regular follow-up, she might have another 4-5 years with medication.
Yes, sir.
Okay. So now how you will plan the investigation?
So first we started the routine investigation for the complete hemogram to look for anemia, if there is a macrocytic anemia or macrocytic apochromic anemia, or there is macrocytic apochromic anemia. Then we check the, sir, LFT for there is any NAS related, rule out the any NAS related CLD or there is a transaminitis. Then we urine culture for the rule out the asymptomatic UTI, sir. Then for fasting blood sugar, HbA1c for the control of the sugar, sir, and for dyslipidemia will check the lipid profile, and also for the chest X-ray and ultrasound will be done for the kidney size, and also there is a check the, sir, if there is a cortical medullary differentiation maintained or not, and is specific investigations we send us our ANA because she is still young. Reproductive age groups are also rule out the connective tissue disorders.
Suppose she is poor, is there any indication for ANA? If you are right in urinary finding,
No, sir.
you can do ANA.
Yes.
Urea itself you can. How many have appeared just theory exam? The final, really practical going on. Yes.
Theory is over.
Who is
Okay.
going to tell everything about proteinuria? छोटे और खड़े हुए गंगा राम का है ना पिछली बार. What is microalbuminuria? Is it right term or something new term has come?
It is changed
Huh?
now. Now it is moderately increased proteinuria. Earlier it used to be called microalbuminuria.
How you will test the proteinuria in urine?
So, you can test first the heat coagulation method. Heat coagulation method can be done. At
Good.
the bedside.
One.
Heat
One. Good.
coagulation. Another?
Dipstick.
Okay. So dipstick से what proteinuria you will detect?
Moderately increased. If it is severe,
Dr. Saab has asked, what do you test in dipstick?
कौन सी प्रोटीन देखता है?
severely increased.
हाँ?
More than 300.
Albumin.
एल्बुमिन देखते हैं बेटा. एल्बुस्टिक्स होती है ना. एग्जामिनर यही पूछेगा फिर तुम यही गड़बड़ करोगे पूरा पढ़ने के बाद.
Dr. Saab, what is the chemical on that?
बोलो.
Cresol. So that is for checking albumin. So you have got albumin stick, not protein stick.
एल्बुस्टिक जो यूजुअली हर जगह यूज करते हैं, कितने रेंज की प्रोटीनूरिया को डिटेक्ट करती है और कितने मिनट में डिटेक्ट करती है? फास्ट टेस्ट है, बताओ. क्योंकि एग्जामिनर पूछेगा यूरिन टेस्ट किया कि नहीं आपने, तभी तो बताओगे. बोलो. कभी नहीं गया लैब में?
More than 300.
गया तो बताओ.
More than
Can you tell me what is the color? What is the color of albumin strip there?
1 minute में you will get albumin stick से report.
What is the color of the albumin stick? And what color it will change?
सिर्फ एग्जामिनर यही देखना चाहता है कि आप लैब जाते हो कि नहीं जाते हो.
All right. So one he said albumin stick. Now you can tell us other methods of checking proteinuria.
उनके इंडिकेट कुछ वो तुम्हारा भी नहीं.
अच्छा चलो.
बताने वो यार
You-
बताएगा.
So one you said boiling method. How do you boil the urine?
We take a test tube and fill urine.
Have you boiled ever?
Yes.
You boil.
तो कितने ml यूरिन भरोगे टेस्ट ट्यूब में बोलो.
2/3 of the test tube.
All right. Good.
ठीक है गुड.
You're slanting. Now what do you add in that?
8 ml बता दो. ठीक है.
Acetic acid.
What? Why do you add acetic acid?
There are phosphates. There will be.
Shabash. Good.
Dissolve.
So that is one. Number two, you said by dipstick. Number three.
So there are other methods like HPLC.
Yeah.
Nephelometry.
What you can do. Examiner is
Sulfur
interested.
क्या होता है?
Sulfur.
Sulfuric acid test.
In the test tube we take urine and add 3% sulfur-salicylic acid.
How much urine? How much
कितना
sulfuryllic
यूरिन
acid?
लोगे, कितना वो लोगे?
equal amount.
Good. Right.
ठीक है. तो then get precipitated. Then you will find the idea कि this is proteinuria. ठीक है. इसमें क्या बता दिया acetic acid और बता. अब then another method, sophisticated method, no high tech. अरे
Nephelometry, immunoturbidimetry,
और
HPLC.
अब
electrophoresis last में नहीं बताया.
Yeah.
टेस्ट करो पहले.
अब बता दीजिए how much albumin normally is excreted. How many types of proteins are there in the urine?
Normal person में how much proteinuria, how much protein is per day, सर पूछ रहे हैं. और out of which how much albumin, कितना होता है normal?
Less than 150 milligram per day.
Very good.
Good.
Out of
Albumin
this,
कितना होता है?
around 20 to 60% of it.
ठीक है, good.
Yes.
Not 60%. It has to be less than 30 milligram.
ना बेटा 30 तो कम रखेगा ना.
All right. तो अब इनको क्या होगा इस पेशेंट को? He said patient is having 2+ proteinuria in the urine. What does it imply? In the urine, when you check protein, he is not talking of albumin.
सर एक चीज और कंप्लीट करने दें, तो पूछते हैं एग्जाम में. अब बेंजोन प्रोटीनुरिया कैसे पता चलेगा? क्या टेस्ट करोगे? जस्ट सॉरी सर.
नहीं नहीं
कंप्लीट हो जाए ना उसको. ये एग्जामिनर ही पूछते हैं सेम यूरिन का एग्जामिनेशन में खिंचाई करो.
What is benzone protein? Answer.
It's a light chain.
नहीं कैसे टेस्ट करोगे?
How do you
We
test?
heat the protein to 60 degrees
इनमें से
Celsius.
कौन सा टेस्ट यूज करोगे बेंजोन प्रोटीन पता करने?
Heat for-
चलो, all right.
heat
Go
for-
ahead.
हीट
You have
क्या
heat.
होता है बताओ? हीट कोagulation में बेंजोन प्रोटीनुरिया
When we heat to 60 degrees Celsius.
कितना
then
डिग्री?
60 degrees Celsius.
हाँ
Then it
55 to 60 ठीक है.
then it precipitates. But when we heat it further to 100 degrees Celsius, then again it clears.
Yes, then when again cool, it will again
It will
appear.
again appear.
This is the best zone proteinuria because dipstick say you can miss the proteinuria. ठीक है?
Now, if suppose in with benzone proteinuria, there may be other proteins also. How do you differentiate?
Dipstick and discordance between dipstick and
So that means when the urine is boiling, then you filter the urine. So if there are other proteins which will precipitate at 100 degree, they will get filtered out. Now you cool it.
Then only you can
Then it will again, if it is benzone, it will again precipitate.
precipitate.
All right. So he has completed benzone for us. All right.
यूरिन में फ्री लाइट चेन ऐसे कैसे करेंगे? बहुत कॉमन क्वेश्चन है.
24 hour
हाँ करेंगे. अल्टीमेटली वही है ना इलेक्ट्रोफोरेसिस इम्यूनोफिक्सेशन.
immunofixation.
ये पता होने चाहिए आपको. मेथड पूछते हैं. लास्ट क्वेश्चन बता रहे. हाउ यू विल कलेक्ट? वेरी सिंपल क्वेश्चन. Urine sample in a male adult and a female patient. And what instruction? Patient basic question. डॉक्टर साहब पहला यूरिन देना कि दूसरा देना? तुम बताओ. चलो उसको छोड़ो. आप बताओ. प्रेजेंट कर रहे हो.
Second
मैक्स
sample.
में जाते हो ना राउंड लेने. पेशेंट
Yes.
पूछता ना कौन सा यूरिन रखना है और क्यों
Sir,
रखना है.
first sample-
कैसे कलेक्ट करना है. सिस्टर को बताते सुनो. बोलो.
The second sample we collect, sir.
What is wrong with the first? And what you will get in first and what you will get in second? बताओ बोलो.
जब कोई भी आदमी, whenever a person is passing urine, the initial sample will come from urethra.
Yes.
So that is a representation of urine which is in the urethral disease. The second sample is going to come from bladder. So initial portion you throw away.
Yes.
And that is why you say midstream. Actually you want that initial 60-70 ml you should throw away. And then take the specimen. That will be midstream specimen. Now the final year student, who is 1, 2, and who is the third?
क्या कारण है सर? तो एक बता दिया सर ने, दूसरा कारण क्या है? यूरिन सैंपल फर्स्ट एंड सेकंड.
Sir, overnight urine is concentrated and there is lysis of cells and fast. So we have a second sample.
Okay. But sometimes to avoid the postural proteinuria, first sample is preferred and second sample is always preferred for microscopic examination.
Now last question of proteinuria, since you are on that. Which is better, UACR, UPCR? Which is better?
24 hours. It's very important question, proteinuria diabetes.
Which one you like? Anyone, you can, anyone.
Gold standard, sir.
Huh?
24 hours is gold standard.
That's gold standard, but you know 65% of the time
Why
collection
gold
is poor.
standard and what is wrong with the spot urinary protein creatinine ratio?
Diurnal variation.
Huh?
There is diurnal variation of creatinine.
Okay, good, one point. That is a very important point. Or
The postural
what are the disease where you will get better information in 24-hour collection?
life changes.
Yes, that is the only important thing. Otherwise, you will get almost the same findings. You will get a rough idea. The only multiple myeloma like this is sporadic proteinuria you will get. So you will miss the amount of proteinuria. Good, bad topic.
And sir, third year.
Now exam going.
Exam going? Who is exam going? Here, no? Yeah, you can stand up. Stand up for them. Difference between UACR, UPCR, which is better?
Sir, usually it is said that UACR is better than urine protein creatinine ratio, especially in cases of early detection of diabetic kidney disease. But mostly UPCR is being used because of more easy to measure and getting it done.
You are
मेथड से करते हैं यूपीसीआर. बताओ कौन सा हॉस्पिटल का? बताओ कौन सा मेथड यूज होता है यूपीसीआर के लिए? इतनी खिंचाई इसलिए कर रहे हैं कि एग्जाम में यूरिन टांग जाओ. इम्यूनोटार्बिलिटी मेथड होता है, उससे करते हैं.
तो ध्यान करिए, both methods are good. Rather, people have studied, they have done UPCR minus UACR. So now the urine becomes non-albumin. So they have tried to correlate, because the question is, you are saying that UACR, UPCR is a reflection of endothelial dysfunction. Because if the urine protein is leaking out of capillaries, there's an endothelial dysfunction. And endothelial dysfunction is correlated with mortality, whatever. Now, UACR is also related to mortality, UPCR also, but some of the studies find that the minus, that is albumin, you remove and it becomes UPCR minus UACR. So that means urinary protein is 150 milligram. Normally 30 milligram is, let's say, albumin. So rest is 120 milligram. So this is non-albuminuric protein. Actually, the correlation of that comes best with the mortality. So all are equivalent and we do not have firm data, but conventionally, as you said, if you have to pick up early disease, UACR is better because you want to find out the albumin that time. But if it is not the early disease, later on, either of the method can be good. Better.
आप बताओ, suppose some patient is catheterized. What is the method of how you will ask the nurse to take the sample, urine sample? And second question, suppose a child is less than 1 year old and having sepsis, then what is the preferred method of collecting the urine sample?
So in
I'm
pediatric,
sorry, very basic question, but these are asked. First examiner, most of the time they will ask only protein and urine.
so in pediatric age group,
Very good.
question is, person is catheterized with a bag. From where will you take urine for culture?
So the lumen.
First year. You get.
Not
उसी को
from the
बताने
back,
तो
but
एग्जाम
the
को
lumen.
From the,
Urinary, the lumen of the port of the catheter.
if the port is not there. There are catheters which have got 3 ports.
Yes, sir.
One port you have attached the catheter. Second port is only for filling the saline.
Yes, sir.
If you have got third port, you can take the culture from there. If there is not, what do you do?
सिस्टर्स को नहीं देखते क्या करती रहती है
We can actually not that.
Say again.
We detach the Eurobag. We detach the Eurobag.
No. That is why the question is, never open the closed system. You are never supposed to open the closed system. Never take urine from the bag. You just clean the tube with the betadine, clap it, clean it with the betadine, and after cleaning, put a syringe, take the urine and stop it. Never open the system. That is why Professor K.N. Singh asked this,
I'm not
that
professor.
so that it should not be done like that. All right, sit
This
down.
is for everybody. Huh? This will be not repeated, at least in our class. But this is very basic thing where you know all nephrology, all studies and everything, and you will fail in the exam.
Now we come to the case.
Case,
Enough
yes.
about this. Now, had you caught the patient 8 years back, she was suppose your patient, she was following your instruction. What you would have done to her for diabetic management?
First, sir, for her, basically for diabetes management, we individualize the sir.
Which is the number one
One.
drug you will like to use for her?
First, we sir lifestyle modification and
Agreed, done. That is already exhausted.
and then first medicine, sir. There is a oral hypoglycemia. Start with metformin, sir,
Okay.
with this SGLT2, sir, inhibitor.
These days, those days, it was not there 8 years back. So metformin, you wanted
Yes.
to start her on. So you wanted to control how much HbA1c you want to bring it down.
Sir, if the target HbA1c for her is 7, sir. If
Which study is showing that? You have to quote the studies now. If you are not there, the final year can help them. Which study has said that you maintain 7? Somebody's mobile is functioning, one can leave and attend the call. Otherwise, switch it off.
जिसमें किडनी फाउंडेशन का है 7. बताओ तो सर बोलो.
Which study? There have been 2-3 studies, DCCT studies, but DCCT was in type 1 diabetics. UKPDS is in type 2 diabetics. So they compared it. So you have to mention that type 2 diabetics, they found that the outcome is better provided you are maintaining it. If you want to maintain below that 7, keep in mind HbA1c is dependent on age.
Yes, that is very very important.
If she was 29-year-old, possibly you might maintain less than 7. Whereas a elderly, possibly even 7.5 is acceptable to you. So look at the age of the person. So you would have maintained a good HbA1c because the studies suggest that you can delay the progression of CKD. Now tell me, had I given to the patient ACE inhibitor or ARBs that time?
sir, she was not hypertensive that time. She was not hypertensive that time.
She was not?
Hypertensive. There was BP was normal.
She was not hypertensive.
Yes, sir.
Then we are not talking about hypertension. Because you will be asked about the study. Any study which says that if I use ACE and ARBs, even in a person who do not have diabetic nephropathy, can I prevent development of microalbuminuria? Yeah, you can. There is a study on road study. So that study has given olmesartan that time. They have compared that patients are not microalbuminuria. They are normoalbuminuria. If you are giving them olmesartan, they gave it for a period of 2.5 or 3 years. they showed that you can prevent development of microalbuminuria. Keep in mind, there is not much data. So let's not start treating everybody with that. That is not the contention. But if you are asked, there is a literature that you can prevent development of microalbuminuria.
That is the sir telling one study. Basic thing you must know in this question. If somebody is having normal blood pressure, suppose detected to be diabetic, and if there is a proteinuria, you have to give ACE inhibitor even the blood pressure is normal, below 110 by 70. There are other studies also where the blood pressure was the normal, there was no proteinuria, and they have not found extra advantage of using the ACE-ARB. But few studies they are favoring. But if somebody is insisting you, if the blood pressure is normal and patient is having micronuria, you must use in a normal blood pressure. That is the only. Otherwise, any proteinuria with hypertension you have to use if there is no any other contraindication. This is the thing. DCGT type 1 immunity type 2 में किसमें हुई थी स्टडी? टाइप 1 में क्या इसका कंक्लूजन बताओ, जो आना चाहिए बताओ.
They compared HbA1c of 7.0 with that of 7.9. They made it two cohorts. So they found that 7.0 HbA1c of less than 7.0% did better in terms of.
See, what I remember, they have kept the in type 1 HbA1c below 6.5 and they have found conclusion. The incidence of microvascular complication all were almost decreased 35 to 40%. That is the conclusion. Then type 2 study is what sir was telling you they have done. The type 2 diabetes most important factor the hypertension is also there. So there was decrease in incidence but not as much as in type 1. That's why it's very important in a diabetic patient to maintain a glycemic control for a prolonged period. Prolonged glycemia or intermittent glycemia, that is the dangerous, and it will predisposing factor of proteinuria or any diabetic nephropathy. So what is your diagnosis? You tell us your diagnosis and report. Something you tell us.
Diagnosis is diabetes kidney disease. Chronic kidney disease with the
Diabetic
5.
kidney disease stage, what stage?
Sir, chronic kidney disease stage 5. We initiated dialysis to stage 5.
Why didn't you use the term diabetic nephropathy? Is it
Sir.
different? Diabetic kidney disease or diabetic nephropathy?
New name आ गया diabetic kidney disease.
Diabetic nephropathy is basically histological.
Is it?
Histological proven diabetic kidney disease, sir.
And diabetic nephropathy and diabetic kidney disease?
Diabetic kidney disease basically GFR is less than 60 with them moderately increased albuminuria in a patient with a long-term chronic diabetes.
So when will you label a person as diabetic nephropathy or diabetic kidney disease? This patient, when the patient came to you 6 months back, can you label the patient that she was having diabetic kidney disease or diabetic nephropathy? What are the 2-3 criteria to diagnose diabetic nephropathy?
So diabetic kidney disease, if GFR is less than 60 with a long-term history of type 2 diabetic and with the moderately.
You telling your patient what are the findings which were favoring the diabetic kidney disease?
Sir, first
6
of all,
months back.
GFR is less than 60, sir.
How you have calculated the GFR? तुम छेड़ रहे हो तो बताओ. How you will calculate the GFR? Not with a smartphone. What is method of calculating eGFR? Bedside. बोलो. अरे आप बताइए. हाँ बोलो क्या होता है बताओ.
140 minus each
हाँ
into weight by 0.72.
हाँ
Creatinine 72 into creatinine.
हाँ creatinine. और female में
0.856.
वेरी गुड. ये आप लेकिन कैलकुलेट करके रखना एग्जाम टाइम पे. सो आपको एग्जामिनेशन फाइंडिंग में एज वेट ये बताना है, रेस ये सब कुछ बताना है. तो eGFR पहले पढ़ाया जाता था बेड साइड. वहाँ पे तो मोबाइल अलाउड नहीं है आपको. देन यू विल टेल मी this is the estimated GFR of this patient. That's why I am telling he is in this stage criteria.
Finally, which equation you are using these days? One, Dr. KN mentioned about cockroach galt.
उससे better वो है.
Cockroach galt you must keep in mind This formula was tried only in 274 to 73 patients, small number of patients, for dose modification, drug dose modification, with practical formula. As I said, for bedside you can calculate, but more reliable formulas are which one you want to use, MDRD or which one? Why? Why not MDRD? So here the GFR is less than 60.
API.
EPI is better even if it is more than 60. 60 to 90 also it is better.
The basic is
So possibly nowadays we are all using EPI equation. You can use MDRD. Nobody will question you if the GFR is less than 60, but EPI will remain better. So at that time, 6 months back, you are saying a person has got proteinuria
Yes.
or albuminuria, the presence of hypertension, and third, you say decreasing GFR. These three things should be there to label a person as diabetic nephropathy. If the three things are not there, you cannot directly label a person.
index
That-
examination also.
And that is what
Having
we.
retinopathy, na, you-
Yes, sir. NPDR.
Then you said protein was 1 plus. What does 1 plus protein imply? How much protein person is passing?
So 100 to 300 milligram per deciliter, sir.
You are taking 24 hours, let's say. If a person is having, though we all say 1 plus protein, these are not reliable things. But if somebody is passing 1 plus protein, what does it imply? It implies 550 milligram or around 500 milligram of protein. That much a person is passing. When you say 2 plus, the person is having significant proteinuria. If it is consistent, though we don't rely on that, that is why you ask for UACR. So 6 months back, patient had come with hypertension. Patient had, I don't know about proteinuria, whether you tested.
8 years back, बोल रहा हूँ ना?
No, 6 months back again the patient came
Yes, sir.
when the creatinine was 3.1.
3.1.
Okay.
So that time patient already had possibly stage 4 or 5, stage 4. At that stage, when a person had stage 4 nephropathy, what drugs you could have given to
Sir,
slow the progression?
SGLT2 inhibitor, sir.
तब तो नहीं थे SGLT2
हाँ.
inhibitor. जब आपके पास patient आया, when were ACE ARBs discovered?
Yes.
2001, almost 22 years back. Then it was proven that ACE and ARBs are better. How much risk reduction they give?
If we use AS and ARB, sir, there is a decrease in GFR by the 5 to, if we do not use the AS and ARB, then GFR decrease to 10 ml per year, sir. If you use the AS and ARB, the GFR reduction is decreased to 5 to 7 ml per year, sir.
You have to know about the risk reduction for progression. You are talking about progression of nephropathy. So ACE and ARB, almost 20% reduction in the relative risk of progression. 20% benefit, isn't it? But that means still chances are 80% person will drop. How much SGLT2 inhibitors benefit?
Around 30%, 32, 30.
Yes, 30 to 40%. That means 20% ACE and ARBs have decreased the progression. Still 80% chances are it is going to progress. If by giving SGLT you have decreased it further by 30 to 40%, so that means 50% to overall, 60% you have checked. But still 40-50% it is going to progress, isn't it? Then of course the newer one, what you have?
SGLT2 and GLP-1 and all.
और कौन सी drug है मेरी पूछ रहा है?
Which one? Whatever, MR antagonist.
MR.
So those are again benefiting by another 20% or so. That means 20%, 30, 40%, 20. So that makes 70%. Still, the patient is going to progress. We do not still have many drugs, and possibly gradually other drugs might come in. Yeah, the trials are on that which will further reduce the progression. So possibly trial, can you name the trials which have shown that proteinuria, even if it was there, it will get reduced by them? Any trials? No. We are talking about ACE and ARB first. Shabash. So one was irbesartan in nephropathy reduction trial, and the second, as she mentioned, was renal reduction in endpoint with losartan. So these drugs were tried, and both were beneficial. But as I said, risk reduction was 18 to 20% only. They have been wonderful drugs. They have been there for over 20 years. All nephrologists are very familiar with that. They feel happy about it, and they are effective. There's no doubt. But you must know these trials. So there is one is, you said, microalbuminuria does not develop. Second is to check micro to macro. Which are the trial? IRMA. Irbesartan reduction in microalbuminuria trial. So their ARBs are better. They are effective. And then if a person already has got macroproteinuria, to check again, as you mentioned, renal and IDNT trial. Trial names you should know. SGLT, I think everybody knows now because so much have been talked about that. But for completion's sake, you can mention that. Which are the trials with SGLT2? Credence, DAPA-CKD, and Emparec. So the difference between these three?
So the range of albuminuria and the GFR also.
So GFR, when you said converse trial, Credence trial, sorry, canagliflozin, they took a GFR 30. That was the cutoff. When it came to DAPA, they took 20. When it has come to Emparec, they have taken 20. So 30, 25, 20.
दापा सीकेडी में और क्या एडवांटेज है एक्स्ट्रा बताया कितने जीएफआर तक यूज कर सकते हैं और एक्स्ट्रा एडवांटेज क्या है क्या मैसेज कन्वे किया दापा सीकेडी नॉन डायबिटिक हो आइदर डायबिटिक हो up to 20 ml GFR तक you can stop even if the once you have started the drug even the GFR falls also you continue there is no side effect you are getting with the drug.
So that is another point what Dr. KN is mentioning to you, that you have started today at GFR of 2022. You say, Baba, Emparec trial says up to 20 we can start. You have started. And rate of drop of GFR per year is how much you said? He said if you are not using any drugs, diabetics may drop by 10, 12 ml per minute per year. If you are using these drugs, possibly your target is to bring it less than 3. Your target is that. Because if the GFR drop is more than 3 ml per year, you call it rapid progressor. If it is less than 3, you say you have achieved the target. So you keep on increasing. You have used the ACE and ARBs. Suppose most common people are using telmisartan, Telma. So if you are using it, make it 40 BD, make it 80 BD, whatever a person is able to tolerate, and then add the other drug. Sometimes people have got tendency ikatti dono start kar do, but that is not the correct scientific way.
Just to summarize, in diabetic nephropathy, as per pathogenesis, you have to remember the 4 points. One is the metabolic derailment, that is control of blood sugar is very important. Second factor is the hemodynamic derailment. Hypertension control is very important. Whatever the drug has discussed, whatever suits the patient. Third, inflammation and fibrosis. That is the progression of the disease. How we will monitor the progression of the disease. That is for that the drugs are there. So you tell me all the drugs, newer drugs which are really having role mechanism of action insert, so that treatment part is over. Now we'll discuss other things. प्रोग्रेशन ऑफ द क्रॉनिक किडनी डिजीज, डायबिटिक किडनी डिजीज को रोकने के लिए क्या है? एक ACRB हो गया, SGLT2 की मैकेनिज्म ऑफ एक्शन क्या है? शॉर्ट में बताओ, कोई एग्जाम में बताओ, आप बोलो मैडम। SGLT का क्या है मैकेनिज्म ऑफ एक्शन? नॉर्मल जी, नॉर्मल ग्लोमेरुलस से और डायबिटिक ग्लोमेरुलस में क्या चेंज करता है SGLT?
डायबिटिक किडनी डिजीज में एफर्ट आर्टोलर डायलेशन होता है एंड ग्लोमेरुलर हाइपरफिल्ट्रेशन which is inhibited by SGLT2 inhibitor, and also due to greater amount of sodium delivered to distal tubule, there is inhibition of tubular glomerular feedback.
Good. So that is the main thing. So ultimately it decreases the intraglomerular hypertension. That is the progression of disease can be inhibited.
And also there is glycosuria and natriuresis.
Suppose what is the superadded action of MRA? Penridone बताया जा रहा है. What is the action of MRA? ACRB RAS ब्लॉक करता है. MRA क्या करता है? बोलो. मैकेनिज्म एक्शन था, बताओ MRA का क्या रोल होता है?
That's a aldosteronism.
Yes.
You have to talk.
सबसे पहले बोलो इससे एल्डोस्टेरोन एंटागोनिस्ट. तो पहले कौन से एंटागोनिस्ट आते थे एल्डोस्टेरोन? पहले तो हमारे पास टाइम पे MRA नहीं था, हम तो अभी भी उसी को यूज कर लेते हैं. Yes.
Good.
So, what is the problem with spironolactone and MRA? Why, in what way MRA is superior?
They are steroidal and
Very
non-selective.
good.
There is androgenic side effect,
Yes.
gynecomastia, and hyperkalemia is also.
And the MRA are short acting. Then other advantage of MRA, what he was telling, it's a pleiotropic effect and anti-fibrotic. क्योंकि upregulation of mesocardial receptors होता है इसमें डायबिटिक में, progression of the disease है. So that is very important drug to aid if somebody can tolerate early stage of the diabetes, no? Because with ACE, ARB definitely the master drug. SGL2 is after that if you are getting it stable then you can add the MRA, but in initial stage it plays very important role.
So जैसे आप mechanism, we are not going in the mechanism or pathophysiology of diabetic nephropathy. Yes, what Dr. K.N.P. Singh was just explaining to you. There are 4 ways that damage occurs. First you say is hyperglycemia or metabolic. So that he mentioned to you. He is mentioning you are giving drugs, and keep in mind many drugs also reduce proteinuria,
Yes,
anti-diabetic.
very important.
Something like linagliptin, that also reduces proteinuria. GLP-1 inhibitors, they also reduce proteinuria.
DPP4,
DPP,
SGLT2.
yeah, SGLT. So these also reduce proteinuria. That is metabolic pathway. Second pathway, Doctor mentioned to you, was hemodynamic. And hemodynamic you have to tackle with again drugs, antihypertensives and possibly Ephren dilators to reduce intraglomerular hypertension. You have got drugs. Third drugs are, at the moment we do not have much. That is growth inhibitors we want, because whatever TGF beta, interleukins, they are increasing. Fourth, as he mentioned, was fibrosis which is developing, glomerulosclerosis which is occurring. For that you have got Finrenol. So you have got now drugs for metabolic, for hemodynamic, you have got for fibrosis, and the growth, there is maybe some of the drugs are acting, but that is one area which can be targeted.
चलो बता रहे थे हिस्टोलॉजी बताओ. मान लो तुम्हारे पेशेंट की किडनी बायोप्सी कर दिया, क्या मिलेगा?
सर हिस्टोलॉजिकल
नॉर्मल साइज किडनी रहती है ना अल्ट्रासाउंड में. माय क्वेश्चन इज व्हाट इज हिस्टोलॉजिकल फाइंडिंग ऑफ डायबिटिक नेफ्रोपैथी? क्या क्या चेंज?
डॉक्टर साहब का पहला क्वेश्चन भी आंसर कर दो. शुड यू डू किडनी बायोप्सी इन द डायबिटिक पेशेंट? एंड सेकंड, अगर कर दी तो क्या मिलेगा?
क्वेश्चन है बोला व्हाट आर द इंडिकेशन ऑफ किडनी बायोप्सी इन डायबिटिक नेफ्रोपैथी?
indication,
टेल मी डायबिटिक नेफ्रोपैथी हिस्टोलॉजिकल फाइंडिंग्स ऑफ डायबिटिक.
sir, there are 4 classes, 4 stages of the classification.
बेसिक
One,
बेसिक बता दो.
stage 1 there is a
ग्लोमेरुलर
GBM
बेसमेंट मेम्ब्रेन में
GBM
क्या
thickening.
होगा, मेसेंजियम में क्या होगा, तुम बताओ ना.
The stage 1 is a GBM thickening, sir.
हाँ?
GBM thickening in stage 1. Stage 2 is a mild meningeal expansion with a less than 25% of the meningeal expansion. And stage 2B is a more than 25% of the mesangial expansion, and stage 3 is a development of the nodular KW lesion, sir. There should be one lesion should be there, and in stage 4, sir, there is a diffuse glomerular sclerosis, sir.
Which is the commonest. By
Stage
biopsy you have done.
ट्यूबलो इंटरस्टिशियम में नहीं अफेक्ट होगा डायबिटीज से, उसको क्यों छोड़ रहे हो? डायबिटीज अफेक्ट्स किडनी में क्या होते हैं? 4 ही तो मेन होते हैं ना
Yes,
बेटा।
sir.
बताओ 4 चीज क्या क्या होती है? ग्लोमरस होता है, वेसल्स
Tubular-
होती है,
tubular
tubes
interstitium.
होता है, इंटरस्टिशियम, चारों जाते हैं डायबिटीज में।
Yes, sir. Vascular there is a
Systemic disorder.
arterial hyalinosis.
हाँ, which is
Arterial
the
hyalinosis, sir. Arterial hyalinosis in
सब
a,
चीज में
yes.
वही तो पूछना चाह रहा है
And tubular atrophy and
पर्टिकुलर एग्जांपल, इससे सिस्टमिक डिसऑर्डर इज गोइंग टू अफेक्ट ऑल द पार्ट।
and there is interstitial fibrillation, tubular atrophy, sir. Also there.
एग्जाम गोइंग बताओ, व्हाट आर द इंडिकेशन ऑफ इन ऑफ बायोप्सी इन अ डायबिटिक पेशेंट?
Sir, if there is an active sediment present in the urine,
say,
भाई एक्टिव सेगमेंट पहले यही बताओ।
sir, either an nephrotic RBC, sir, more than 3 RBCs.
क्या पिक्चर को बोलते हैं? एक्टिव सेगमेंट को पिक्चर को क्या बोलते हैं? हम लोगों को पढ़ाया जाता था सब डांट के पूरा। हाँ यस, टेलीस्कोपिक। बचपन में तो अब तो मॉडर्न जमाना आ गया ना, पहले आसमान दिखाया जाता था ना, टेलीस्कोपिक पिक्चर। You will get everything in finding that.
if you put a telescope, you get a wider view, you get everything. So when you're saying active sediment, you have to have proteins, you have to have RBCs, you have WBCs also.
So that is the if you are getting active sediment. एक नंबर। दूसरा
The rapid deterioration in GFR, sudden abrupt rise in proteinuria.
वेरी गुड, मतलब सडन एब्रप्ट राइज इन प्रोटीनुरिया। ओके, दैट इज रैपिड जीएफआर। यस, और कुछ है?
RBC
No
cast.
retinopathy.
Yes. No retinopathy and you are sometimes मतलब unexplained renal failure. Then you have to do, these are the causes. सही है, good. ये भी पूछा जाता
But
है।
keep in mind, many times we do biopsy in many patients. I must have done in almost 100 patients. Diabetics, you find the GFR is rapidly deteriorating. Unfortunately, you don't find a cause. So there are subset of patients, you do whatever you want to do, but they progress faster. I think there's somebody in
That is
AIMS.
genetics है ना, heterogenic
Yeah,
है।
that is
Diabetes
why-
के बारे में कुछ पता
That is why, as he gave history, that mother is a diabetic in this patient. Genetics, we don't know much about it, but we know that there is a racial difference. When you say Pima Indians, they breed in US close to Mexico border, and there almost 85% of the people are diabetics. Practically everybody is a diabetic there. So race is affecting. Likewise, the genetics, the parents are giving it. We do not know exact why the genetic predisposition, but yes, that is why it is heterogeneous.
in spite of doing all the things. Even suppose somebody is having family history of diabetes, डॉक्टर साहब मेरे को डायबिटीज से किडनी डिजीज नहीं होनी चाहिए। You do whatever, the progression is going to occur. There are so many factors. There is a strong family history. So, but you can retard the progression. Even up to the patient is progressing to stage 5, if you do the proper treatment with antihypertensive drugs, correction of anemia, calcium, phosphorus, PTS, everything, then patient will be asymptomatic. So, चलो आगे बताओ और क्या डायग्नोस रिपोर्ट्स बताओ कुछ।
अब पेशेंट ये प्रोग्रेस कर गया भैया, अब ये अब तो डायलिसिस पे आ गया,
Yes, sir.
अब क्या करना चाहते हैं?
नहीं, अभी रिपोर्ट्स तो बताने को सर। क्रॉनिक
बताइए।
डिजीज के में एडवांस स्टेज कैसे बता दिए। CKD5 हो गई, नॉर्मल किडनी तो अल्ट्रासाउंड में नॉर्मल है ना?
Yes, sir. 10.3 and 10.7
ठीक है,
centimeter.
मैं तो कह रहा हूँ नहीं है, SLE है। बताओ क्यों नहीं है SLE?
So ANA basically we
हाँ?
do
डायबिटीज
a
पेशेंट को भी तो SLE हो सकती है। डायबिटिक नेफ्रोपैथी के साथ सुपरएडेड हो गई, बोलो क्यों नहीं है? तभी तो कह रहे हैं रिपोर्ट्स बताओ बेटा अपनी। पहले फर्स्ट हिस्ट्री इज वेरी इंपॉर्टेंट। हिस्ट्री इज इन फेवर ऑफ chronic kidney
chronic
disease.
disease, sir.
ठीक है, now you tell the what are the lab reports which are in favor of your chronic kidney disease and doesn't require biopsy. Then you label the patient, make AV fistula, go for transplant. How you can say transplant to anybody if there is some acute factor?
So there is a increased IPTS level. IPTS is 377, sir. There is anemia favoring HB is 8.3, sir. Raised IPTS, sir.
IPTH कितना है?
377, sir.
हाँ?
377.
Usually चलो बताओ अच्छा और 677 IPTH हो गया और
And anemia 8.3 hemoglobin and ANA was negative. Did we ANA was negative.
Where did you do ANA? Was ANA required?
बताओ सर पूछ रहे हैं.
No, sir.
You have checked the urine.
Yes, sir.
You are fine. You have done UACR or UPCR, anything?
Yes, sir. USCR is a 5,300, sir.
Keep in mind, when a person is almost in end stage renal failure, these data are not reliable. Whether you are doing UACR or UPCR, early stages, yes. Once a person is already in end stage renal failure, the glomeruli are already gone. What are you trying to get? They are already damaged glomeruli, so they may not be having a good reflection of whatever is the proteinuria. So, but anyway, your patient has significant amount of proteinuria. What is important, what Dr. K.N. Singh is trying to point out, do not close your eyes that it is only diabetic nephropathy. There can be concomitant membranous nephropathy, there can be some whatever. Other diseases can be there along with that. Don't close your eyes. A diabetic can also get multiple myeloma. A diabetic can get whatever disease. So keep your eyes open. Look at the urine sediment. What you are saying, you are not finding much of RBCs there. There is just protein. Your kidney size are big, normal. They have not shrunken at the moment. Do you expect shrunken kidneys or normal kidneys?
So normal kidneys.
Why?
In diabetes, sir, there is a normal kidney with the. In diabetes, the kidney size is usually normal.
That's all right. Because of the hypertrophy, they initially hypertrophy. But generally, you have to think of the ecogenicity also.
Yes, sir.
Because ecogenicity must be increased
Yes, sir.
by the time you look at that. So look at that. Kidney may be normal size. So you have got retinopathy. You have got a good history. You are not going for anything else. You do not require. And the patient has progressed over 8 years to advanced kidney failure. That is a normal phenomena possibly you will get. So in this case, you may not entertain other diagnoses.
आप अपने इस पेशेंट में डायबिटिक है, हिस्ट्री से फाइंडिंग से क्या एक्यूट फैक्टर देखना चाहोगे इंपॉर्टेंट एग्जाम गोइंग बताएं.
Infection.
चलो आप बताओ एग्जाम गोइंग बताओ. डायबिटिक है विथ हिस्ट्री विथ इन्वेस्टिगेशन, बट स्टिल ही वांट्स टू लुक द एक्यूट फैक्टर. Even if you can correct the 10 ml, 20 ml, 10, 15 ml GFR, she will free of hemodialysis for another 6 months to 1 year. So what are the acute factors which you will look? Anyhow, if he is doing NA, I don't mind in doing the female, but since she was having previous history 8 years back, then all these things and all positive, so 99.9. But what are the acute factors, especially in our Indian patient? Huh?
No, what he's saying is, patient has come.
Okay.
We don't know history. It is possible it may be acute on CKD. Our job is to find the acute insult.
One, she is telling infection.
Yes.
There is no evidence of infection.
No, sir.
Second, the commonest drug patient
Drugs.
used to take a lot of indigenous medication. One is painkillers, some desi medicine. That's a very common. AIN is the commonest thing. And suddenly she presented with flu or low.
So keep in mind infections. That is one. Because which are,
Contrast.
can you name few infections which are common in diabetics? Simple. Harrison. Which, when if you are asked specific for diabetes, that is one. No, name any infections, not diabetic nephropathy, in a diabetic, which are peculiar to a diabetic.
Emphysematous pyelonephritis.
One, you talk of emphysematous pyelonephritis.
Yes.
You talk of
Otitis
emphysematous
externa.
cholecystitis. You talk of
Otitis externa. Malignant otitis.
Pseudomonas causes otitis externa. And
And
there's one more infection. So these, say again? Fornius gangrene. No, there's maybe that.
Rare.
So rare. So there are some infections which are peculiar to diabetics. So you have to keep in mind whether a person has got acute insult due to infection. Dr. Saab mentioned to you indigenous drugs in India. Possibly you can correct these things. It is very difficult. You will have to rely on history.
Yes, sir.
It may be very difficult to correct or to come to diagnosis unless you do a biopsy. There are many patients you find. We started looking at, there was a time long back when there were no drugs for hepatitis C. A drug came, glycerina, that is Molatti. Many of you may be knowing. So our hospital, Army Hospital, that time they tried a trial of glycerina, Molatti. That was for hepatitis C. And our 30, 40 patients, transplant patients were on Molatti. And that's a tablet. And suddenly we found 2, 3 of them having a rising creatinine. We did a biopsy, sent it to them, and the pathologist said, I have never seen such biopsy, full of eosinophils. Which is the stain for eosinophils?
Henson.
If I
Henson.
Hensel and Wright.
Right.
All right. When do you call it eosinophiluria? More than 1% of the sediment should be eosinophils. Anyway, so that is how we treated them with steroids and they reverted back. So keep in mind, if a person has given you a history that a person has been taking indigenous medication, they can cause. And I won't hesitate to do biopsy if all the other pointers are suggesting that if you say 3.1 was the creatinine few months back, 2 months back, today he has come for dialysis, a rapid progression, that is what she said indication for biopsy. If the GFR has rapidly deteriorated, think even if you are not getting a cause, you might do a biopsy. All right. Now, you
IPT, sorry, sir.
yeah, please go.
Old IPTS 676. Usually in diabetic, what PTS you
So
will get?
376. I told 376. 376.
376 is also high. Usually in diabetic, what type of bone disease you will get? Expect normal, maximum. Head angina.
Head
So
angina.
don't get confused. Most of the time you will get normal PTS. So it doesn't think that. But in other disease, if the PTS is high, that is one pointer in lab that favors chronicity of the disease.
Now the patient started dialysis. She says, "Meri sugar theek ho gayi." Is it common that she has been taking previously all the medication
Yes, sir.
and suddenly she said, "Meri to sugar achhi ho gayi"? Is it common?
Yes, sir.
It's common. Yeah, go ahead. Why? So that is one is clearance of insulin. 60% is cleared by kidneys. So it is not getting cleared. So there is a prolonged action of insulin. Number two, you said the appetite is not there. Person is taking less food. So, and one or more factor, anything. So these will cause. So these will cause the sugar level might become normal. So don't get surprised. I can't give you a correct figure, but almost 30 to 50% require lesser hypoglycemic agents than they were taking before. Diabetics. Now, finally, he has come for now.
For the final treatment.
That-
Suppose all modalities, CAPD, hemodialysis, transplant, everything is available in your institute.
Yes, sir.
And patient is also ready to accept all the treatment.
Yes, sir.
What treatment you will offer?
If she affords, sir, we go for a
Huh?
transplant. She's younger.
It's not, I told you, she can afford all the treatment.
Okay.
What treatment you will offer in this patient?
So transplant.
Why?
Kidney transplant. Because she's young.
Why,
Sir,
why
she's 37-year-old.
transplant? Tell me the point in favor of transplant. That is my question.
The first, she is a 37-year-old.
Young patient.
Yes, young patient.
Young adult patient.
Yes, sir.
That is the one. Second, my indirect question, what are the contraindications in a diabetic for transplantation? Same thing you tell me.
If there is a HIV infection or
Exam going, bolo. Bata beta. What are the complications, contraindications of transplantation in a diabetic patient? Bata.
Active infection, malignancy.
Active infection.
Why are diabetics more prone for malignancy? He's asking, is a diabetic.
वो सही बोल देखो malignancy infection कोई भी है तो आप कंट्राइंडिकेशन इन एवरी केस बट डायबिटिक में क्या प्रॉब्लम होगी कि तुम कंट्राइंडिकेट करोगे बताओ कि नहीं करोगे हिंट बता दें चलो ज्यादा एज है पेशेंट की आप बताओ
हाइपोग्लाइसेमिक है
Hmm.
माइक्रोवैस्कुलर कॉम्प्लिकेशन है तो क्या क्या डायबिटीज के कॉम्प्लिकेशन
माइक्रोवैस्कुलर
नहीं ना मैक्रो का क्या?
है उसका ब्लैडर ठीक नहीं है ब्लैडर कंट्रोल नहीं तो इज प्रोन टू गेट इन्फेक्शन ठीक है या पेशेंट को और क्या होता है पेरिफेरल वैस्कुलर सीवियर डिजीज है हाउ यू विल डू द ट्रांसप्लांट सो इसलिए दीज आर द
So bad peripheral vascular disease, if there is a diffuse atherosclerosis, may not be in this patient. You might have to rethink. And keep in mind, for those people, even a atheromatous plaque dislodging, that again is cause of rapid deterioration of kidney function in old age. This is a young lady. What is the target organ involvement in her? She has got retinopathy.
Sir, yes.
Everything. She had neuropathy. She has got diabetic triopathy.
एथेरोस्क्लेरोटिक डिजीज ऑटोनोमिक डिसफंक्शन पोस्चरल हाइपोटेंशन और गिर जा रहा है कोरोनरी डिजीज की सीवियर हिस्ट्री है पुअर एलवी डिसफंक्शन है लाइफ की प्रोलॉन्गिविटी बहुत ज्यादा नहीं है देन व्हाई यू विल ऑफर ट्रांसप्लांटेशन ठीक है These are the- अच्छा अब तुम ही पूछ लो क्या पूछना है बता यू टेल अस एवरीबॉडी व्हाट इज योर फाइनल डायग्नोसिस मैं केस में तो कुछ था नहीं बेटा मतलब सिंपल सा केस तुम पकड़ लाए ओपीडी
So it's a chronic kidney.
ये बताओ कोई चीज छिपा के रखे हो
So you give the final diagnosis. What will you say?
So this is a case of the chronic kidney
जोर से
disease.
बोल सब कुछ सुनाई
Chronic
पड़ता है।
kidney disease, sir.
पीछे वाले से पूछो क्या डायग्नोसिस बताया
The case of the chronic kidney disease, possibly a diabetes kidney disease, and
No, exam में लिखना है आपको diagnosis. What will you write?
अभी एग्जामिनर के पास टाइम है तो उसी तुम्हारी डायग्नोसिस से समझ जाएगा तुमने क्या बताया या हिस्ट्री सुनेगा बताएगा क्या
so sir, this is
सर
a
जैसे एग्जामिनर पहुंच गया तो कहेंगे डायग्नोसिस बता दो जल्दी में उसी से पकड़ लेंगे
क्या लिखोगे diagnosis?
हाँ बताओ
Second year वाला क्या लिखेगा?
so the syndromic diagnosis is a chronic kidney disease,
Chronic kidney disease.
ठीक है
Chronic
chronic
kidney
kidney disease
and it-
syndromal है फिर
and sir there is a
cause बताओगे
etiopathiological diagnosis is a diabetic kidney disease, sir.
हाँ टाइप
And
2 डायबिटिक किडनी डिजीज डायबिटिक नेफ्रोपैथी टाइप 2 डायबिटीज मेलाइटस और क्या
Yes.
बोलोगे
And sir newly onset hypertension.
Huh?
Newly onset hypertension.
Newly onset.
ये हाइपरटेंशन तो डायबिटीज
ये
के
तो-
साथ रहता ही है बेटा टाइप 2 डायबिटीज के साथ
And triopathy, sir.
डॉक्यूमेंटेड हाइपरटेंशन है एक्सेलरेटेड हाइपरटेंशन की हिस्ट्री है तो आप बोलना चाहो बोल दो जो लिखते हो आप लोग अदरवाइज इसका तो क्रोनिक किडनी डिजीज डायबिटिक नेफ्रोपैथी या डायबिटिक किडनी डिजीज एक लाइन में डायग्नोसिस बता दो तो जरूरी नहीं तुम्हारे उसमें बहुत है तो एग्जामिनर का अगला क्वेश्चन होता है व्हाट इज योर डिफरेंशियल डायग्नोसिस तब बताओ या व्हाट द थिंग्स व्हिच यू रूल आउट ट्राई टू रूल आउट अभी बता चुके हैं ऑलरेडी सब डिस्कस हो गया फिर वही याद रखा करो ना एक्यूट फैक्टर है
Yes, sir.
यंग फीमेल है सर मैं एसएलई रूल लगाऊंगा ठीक है थॉट प्रोसेस चेक करते हैं ना आपका फिर मैं इन्फेक्शन रूल आउट करूंगा इस पेशेंट का कि कोई इन्फेक्शन तो नहीं है कोई ड्रग इंड्यूस की हिस्ट्री तो नहीं है ये सब देखोगे ना तो ऐसे बताना है हिस्ट्री का यही है
अब ये यूरीमिया में आ गया पेशेंट. Do diabetics tolerate uremia better or poorly? एक normal patient है, one is diabetic. Who will tolerate uremia better? CKD stage 5 better. Diabetic will not tolerate because of associated complication. Doctor mentioned in between, you didn't catch it. A person will have diabetic gastropathy. He will have more vomiting. He will have diabetic cystopathy. Urine नहीं निकलेगा उसका. He's had got retinopathy. He may be half blind. So they are not. They will have type 4 RTA, the hyperkalemia. So diabetic do not tolerate uremia well vis-a-vis other people. So here he has presented today. Don't mind. You have to be little more loud and slow. Just see that people catch what you are saying.
फास्ट मत बोलो
All right.
दूसरे लोग सुन लेते हैं
We are not. That's a good practice you are doing. So you have presented a case of one is diabetic nephropathy, stage 5. All right. KDCO classification. You know KDCO
Yes, sir.
or KDOKI. So
तुम अच्छा
they
केडीगो का फुल फॉर्म बताओ, सॉरी बताओ केडीगो का फुल फॉर्म क्या है? अरे बताओ ना, बताओ गंगाराम, केडीगो का फुल फॉर्म बताओ।
Kidney disease improving global.
आप केडोकी का फुल फॉर्म बताओ। किडनी
Disease outcome quality initiative.
ये आजकल कौन से वाला पढ़ते हो KDOKI classification जो चार्ट रोज पढ़ते हो? This came in 2012, isn't it? So it gave you 3 more changes than before. One change was it brought stage 3 to 3A and B. Second stage was it gave albuminuria definition A1, A2, A3. And third, it said you must give the etiology along. So what he is saying is it's a diabetic kidney disease, a diabetic nephropathy with advanced kidney failure at stage 5. That suffices. Patient presented to you with fluid overload, that is fine. And
केएफटी वगैरह भी कराया होगा ना, क्रिएटिनिन
Yes, sir.
7 कितनी
6.7, sir. Urea is 277. Creatinine is 6.7.
और क्या क्रोनिसिटी के फेवर में?
So calcium is 7.
कैल्शियम फास्फोरस क्या है?
Phosphorus is 5.7 and average is calcium 7.9.
एनीमिक भी है।
Yes, sir. 8.3.
any questions from them now?
और पूछना हो कुछ भी।
There was nothing challenging in the case at the moment. It was a simple diabetic nephropathy.
But it's a daily, you will get out of 5 patients in OPD, 2 patients.
Always.
Two,
I have
three
been
patients
taking
you get from.
DNB exam at least for last 18-20 years consecutively, and always we ensure that one diabetic nephropathy is kept, because one, it's so common a disease. Second, in your life practice you may not see fibrillary nephropathy or this and that, but diabetic every day you will see. I think half of your clientele will be diabetic nephropathy. That you must know.
Majority of time we'll see diabetes with complication. And one important thing we have forgot to discuss, vascular access is a big
Yes.
in a diabetic patient.
Keep in mind, if normal vascular access you make when the GFR is less than 20, here possibly less than 30 you start thinking of that, because atherosclerosis, the vessels, the fistula is not going to form.
They get closed, we need graft, we need this sometimes.
Any question? If we have
इसी से
anything, no.
डायबिटिक पेशेंट में CAPD का कब इंडिकेशन होगा? ट्रांसप्लांट से भी ज्यादा सुपीरियर कौन कौन से केसेस होंगे?
Failed vascular access because of
फेल्ड वैस्कुलर एक्सेस, इसी से याद आया ना। और
cardiomyopathy.
वेरी गुड, पुअर इजेक्शन फ्रैक्शन, पेशेंट अनफिट है ना, डायलिसिस हीमोडायलिसिस टॉलरेट करना ट्रांसप्लांट के लिए, तो ये कोई नॉन रीनल इंडिकेशन है CAPD का?
CLD.
क्या
CL.
Related CLD.
है? नैश रिलेटेड CLD, और CLD में रीनल फेलियर तो होगा, और क्या है?
पहले हमारे टाइम
किसी
में
पेशेंट का नॉर्मल रीनल फंक्शन है
हाँ,
और उसको कोई इंडिकेशन है CAPD का, जहाँ एडवांटेज होगा बता, कौन सी एसिड है बताओ, तो थैंक यू को नोट करें चलें। हाँ हाइपो, चलो उससे तो हीमोडायलिसिस करो, जल्दी टेम्परेचर ठीक हो जाएगा। पुअर इजेक्शन फ्रैक्शन रेजिस्टेंट CHF में बेटा आप करो CAPD वंस डेली करते हैं, एक बैग किया, अल्ट्रा फिल्ट्रेशन कर दिया, ड्रग्स नहीं काम करती, डायबिटिक रेजिस्टेंट हो जाता है। कार्डियोलॉजी में कितना करते थे गंगाराम में, या जितना पुअर एलवी फंक्शन का पेशेंट आता था जिसको हार्ट ट्रांसप्लांट की जरूरत है, अब वही आगे जाके कार्डियो रीनल सिंड्रोम हो गया, रीनल डिसऑर्डर, तब भी CAPD प्लेज वेरी इंपॉर्टेंट रोल।
rather the RRT of choice in our time used to be give CAPD to diabetic patients because of whatever you said.
एग्जाम में CAPD पूरा पढ़ लीजिएगा, CAPD का एक चाहे क्लास लगवा लीजिए आप लोग, CAPD पूरी पूछी जाएगी, ऐसा नहीं है।
Fine. Thank you.